Welcome to HEA's Hypno Connect, the podcast by the Hypnosis Education Association. Real conversations, expert insights, and meaningful connection. Brought to you by HypnoBiz in a Box, the ultimate all-in-one hypnosis business platform. Let's get to it.
Hey, everyone. Oh, look, there's some bacon on the screen.
Oh, yeah. Art brought the bacon.
That's so good. So good. All right. Awesome. We're so excited to hear from you, Dr. Frederic Mau. Let me get that pin working properly. Remove that pin and pin you because you're the one that everyone's come to see. Awesome. Wonderful to see you in your bright office here.
Yeah.
And we're really excited with what you have to share with us.
But first, I got to know about the paddle.
Oh, yeah. Okay, so this is a well, let's see. Let me see what we've got up there. So on the paddle, we have a picture of a rabbit smoking a pipe. This is a Native American motif. Can you guess what is on the other side of the paddle?
I wish I could see it better. That I could tell you. So rabbit smoking a pipe on one side.
The back end of the rabbit?
Smoking a rabbit?
Pipe smoking a rabbit.
The back side of the paddle is a panther. And I'm of course smoking cessation sign I do, but the reason the rabbit is smoking the pipe in a traditional motif is that he is at peace, at ease, and comfortable. And the reason he's at peace, at ease, and comfortable, even though there's a panther back there, is he knows he's smarter than the panther.
Cool.
So sometimes we have the panther out, sometimes we have the rabbit out. It's always fun.
Awesome. Beautiful. And where did you get it? Where did you get that paddle?
Oh, an artist crafted it for me.
Lovely.
Yeah,
love
cool.
it, love it, love it. Thank you.
When my eyes see something, my brain has to ask questions. So yeah, thank you for that.
Oh, yeah, it's a great story. There you go.
So, all right.
Yeah, we're excited. You know, do you have slides you want to share? Do you want to take
He's all
over?
ready
You
to
want to?
rock and roll. And
Okay.
we've got some people here. And what I'd encourage you to do is if you've got something to question Dr. Frederic about during the presentation, you can use the hand raise feature. Or you can just put it in the chat. I'll watch the chat and make sure that we get those questions answered. So you can go ahead and take it away.
And same if you're watching on Facebook.
We
if you
are
have
streaming on
questions
Facebook. So if you have questions either now or on the replay, you can hashtag replay, please. Thank you. We'll make sure those get answered too. Awesome.
there. Okay.
So I am going to do a little bit of PowerPoint and kind of talk along a bit, but you know, if me just wandering on is not your cup of tea, then you can like jump in questions, that kind of thing. It's nice to have discussion. We're not too formal here, so let me grab the screen sharing, and we've got the presentation here. If it will give me my cursor, and let's see. It takes a moment to get it where it's supposed to be, but there you go. So we've got like Hypno Connect. I did have a little slide that was a little bit of a resume. I'm not going to linger on this long. And you said nice things about me at the beginning, so I really, really appreciate that. I am super excited about something, though, that I'll mention right quick that's on here. And that is I'm getting to contribute to the upcoming 5th edition of Essential Psychopathology and Its Treatment, which is a standard medical textbook for psychiatrists. They have already adopted my section on hypnosis, which is awesome, and I'm happy about it. And they have asked me to expand and edit and write substantive contributions to their, as of yesterday, to the chapter on general psychotherapy. So I'm really happy about that. Like that's you know, that's a major thing. So it's just lovely. This is a friend of mine, Melanie. You mentioned the UK conference when we were chatting right at the beginning. I saw Christodora about a month ago now, I guess, at the UK conference in London. She's a Spanish hypnotist, and she is just lovely, and gave me permission to use this photo. You can see Christodora with a full body catalepsy here. I did not hypnotize her this time. I have done full body catalepsy with her before, but it was not in as cool a setting where she's like stretched out between a couple of rails overlooking, I don't know, is that Las Vegas or something? Nice views in the background. The thing about it is, if you try to do this with someone in waking state, it really doesn't work. Like, you can have a good plank and all that, but having someone just totally stiff and rigid. When I did this with Christadora, it was 2 years ago at the London conference, and I just did it with her standing and then leaned her all the way back on her heels until she was laying down on the floor. You can't do that with someone who's in waking state because they're going to bend in the middle. It's just sort of instinct in the way things go. If I am at a party and I hypnotize someone so their arm is stiff and rigid, and I try to tell them to move their arm and they can't, clinically trained observers can't tell the difference between hypnosis and waking state behavior, just holding your arm still. But these things actually look very, very different in the brain. Waking rigidity is really in the prefrontal cortex, the number right posterior cortical structures. Hypnotic paralysis involves completely different regions of the brain. And I know you're not neurologists, and so there's not an anatomy test at the end of this, but I do want you to have kind of a sense that when you're consciously doing something, a different part of your brain is involved than with hypnotic phenomena, like hypnotic paralysis, which involves the orbitofrontal cortex, the cerebellum, thalamus, pituitary. Again, I know you're not neurologists here, but this is actually from the Ward study that's cited in the previous slide. By the way, if you want the slides, just let me know and I'll be happy to send them to you. They've got all the references and stuff. But if you look at the pictures here, you can kind of see what's going on. On the left-hand side, item A, this is hypnosis. The person attempts to move and they find that they can't. And if you look at the upper left picture, and then if you compare it to the one in the middle, the upper left picture, that is waking state behavior, just holding your arm still. And then item C on the right are areas of the brain that are common for both. But you would compare the upper left with the upper left with the upper left, the upper right with the upper right with the upper right, and then the three bottom across the bottom with each other. And, you know, even if you're not like all up on your brain regions, you can easily see that hypnosis is involving very, very different parts of the brain. Of course, there's some overlap, things like the motor cortex. But the point being that the question of is hypnosis a state or not, I mean, honestly, that question has more than been answered. And hypnosis is not simply compliance. It is very different from waking state behavior, which is really important for what we do as therapists. When you tell someone to try to move their arm and they can't, there's an interesting thing that happens with the motor cortex where it sort of pre-activates. So if you think of the motor cortex, when you move your arm, it's sort of going, vroom. But if you think of it as in hypnosis, trying to move your arm consciously, but your arm won't move, it's kind of like the motor cortex goes, and just kind of drops off. There's a little residual activation of the motor cortex without movement that's consistent with people saying, hey, I tried to move my arm, but it doesn't really engage. And so you don't really have that movement. And so the point of these couple of slides is just hypnosis is different. It's not compliance. It's not waking state behavior. It's operating very differently. And a key factor about it is that it feels unconscious and automatic. And that becomes very important as we talk about therapy. When we think about hypnotizability, there are differences in hypnotizability. I know people will discuss this, but we've had behavioral measures of hypnotizability for 60 or 70 years. There's the Stanford scale and the Harvard group scale and the HIP, which is what everyone uses for research. I got to see David Spencer at the London conference here a couple weeks ago out at Stanford, and he's, I guess, the leading researcher in academic hypnosis for like the last 30 years. And his father, Herbert, before him was the leading researcher in academic hypnosis, and is the guy that designed the HIP, the Hypnotic Index Profile, to measure hypnotizability. With brain scans, we asked the question, hey, are people that score as more highly hypnotizable, is there something different happening in their brain? Like, can we see what high hypnotizability looks like on a brain scan? And the answer is yes. High hypnotizable people have a greater functional connection between the prefrontal cortex, which is an executive control region, and the limbic system, the salience network, this is the part of you that's in charge of your survival and keeping you safe. It runs fight or flight. It's definitely involved in anxiety responses, post-traumatic responses. If you really want to look at one part of the brain in terms of hypnosis, I would kind of point out the anterior cingulate cortex. And what you see with people who are highly hypnotizable is that they have a greater functional connection between the prefrontal cortex and the anterior cingulate cortex. It's not due to differences in brain anatomy. Those two regions are really hardwired together, tied in the primate brain anyway. But in people that are more hypnotizable, they coactivate, they fire at the same time. So they're just going at the same time. That coactivation is the key defining characteristic of high hypnotizability. When you hypnotize someone, what we're actually doing is breaking those things apart. So there's a decoupling of the anterior cingulate and the lateral frontal cortex. Frontal lobe functioning is reduced in hypnosis. And in people that are highly hypnotizable, anterior cingulate and prefrontal activity is highly increased, even though those two are not together. So I'm going to stop sharing for a minute because I know I've done things that are real technical here for a moment. And just want to kind of grab this. So your prefrontal, which is right here behind your forehead, your anterior cingulate, which is midbrain, those two regions are really hardwired together in primates anyway. But in people that are more highly hypnotizable, they fire at the same time. When you hypnotize someone, what you're doing is kind of breaking these two regions apart. The activity level for both of them goes up, but they're no longer firing at the same time. And that is a characteristic of high hypnotizability. So I figure this is probably a good point to stop for a moment. And did that make sense? Is it interesting? I'm going to take a sip of tea. What did you think?
I'd say the significance of them firing at different times when hypnotized, is that what we're doing essentially when we're unwiring like you're working with trauma and anxiety? You're actually teaching the brain to behave differently, even, considering that old. So in other words, a trauma memory might fire up when somebody's awake, PTSD flashback, right? They're firing together. But somehow in hypnosis, you're saying what we're doing or what's happening is those are actually sort of coming. They're not. Is that
I
what you
think
mean?
what's happening is we're kind of breaking apart the part of the brain that remembers, hey, I'm supposed to feel really bad, which would be your
Right.
prefrontal cortex.
Yeah.
And the emotional processing over there in the limbic system with the anterior cingulate. And by breaking those apart, it allows us to sort of rework things.
Excellent.
I think that's kind of the key. People that are more highly hypnotizable have a more effective frontal limbic system. And so I think one of the reasons we get, you'll see in a moment, high hypnotizability definitely correlates with more likely to have post-traumatic responses that are clinical. And I think these two things operate in the same way in the brain. It's the tie between the anterior cingulate, the limbic system, which is the emotional processing part of the brain. I tend to think of the limbic system as the subconscious or the unconscious. And the prefrontal cortex, because those two things are so engaged together in people that are highly hypnotizable, and it actually is to your advantage. But if you run into a really bad situation, it means that a post-traumatic response that's clinical is much more likely. So when we're treating that kind of thing with hypnosis, we're taking advantage, I believe, of the same brain functionality that got you in trouble to get you out of it.
Mhm.
Wonderful.
We're working with the
Yeah.
same thing underneath. I'm going to try not to be, too high level with this. I think it is helpful though for us to kind of understand our processes. Lori.
Yeah.
Oh, you've
Actually,
got your
Art
microphone
had a
muted.
question.
Art had a question too. And then I
Yes.
see you.
My
I'll grab
microphone
Lori and then I'll grab
disappeared.
Art.
My microphone disappeared there. So,
Say
so the way that is working, like with a somnambulist, somebody who is just highly suggestible to a lot of things, both of those areas are kind of going off at the same time. Is that
in
and so they
normal
are more
waking state,
suggestible
both
to
of
the
those
trauma?
regions are going at the same time. In hypnosis, what we're doing is breaking them apart.
Okay, because the reason that they are having a larger clinical post-traumatic response is because they're going off at the same time, is what you're saying initially. No, it's opposite.
No, you're not wrong. In general, what's happening is because those two things are tied together, there's more of a connection between what you can think of as cognitive processing and emotional processing.
Got it.
It's more effective, which is great if things are lovely. But if things are really bad, being more effective is kind of bad. It sort of brings home the traumatic experience, I think, to a greater degree. Does that?
That's brilliant. And what I'm hearing you
Yeah,
say
I
at the same
understand.
time is if they're highly suggestible people, you can
Right.
recognize that when they walk in. That's probably why they're having such a hard time, but we can use that to our advantage.
Right, and suggestibility and hypnotizability are basically equivalent terms in clinical literature now. Hypnotizability is definitely the preferred term, and I think the reason is it doesn't get confused with like, hey, let me give you a suggestion of what you might like for Christmas. You know, when we're talking about hypnotizability, it's not just, hey, here's some suggestions. And so we do talk suggestibility, but if you're reading scholarly articles, hypnotizability is going to be the language that gets used.
Awesome. And I know Art had a question.
Yes, sir.
Yeah, just a humorous comment. I've had clients come in and say, well, you can't hypnotize me. Is it true that some people are not hypnotizable? And I always say, absolutely true. There's two groups, and you might be in one or the other. I don't know which one. One of them is people with an IQ below 60, and the other one is long-term hard drug users. Which group do you think you fit into? And they, oh, I'm not in either. I said, well, then you're probably hypnotizable. I said,
You're not wrong about that. I mean, those are definitely things that can throw things off. I believe everyone can be hypnotized,
yeah.
but there are people that are more highly hypnotizable, which is not something that I bought into for a while, but there's nice research on it. I'm going to press forward a little bit and get a few more pieces on the table for us that I
One
think.
more quick question
Oh,
from
okay, go
Illa,
for
and
it,
then we'll go.
please.
Thank you.
It's actually Isla,
Isla, thank you. Sorry.
no problem.
Hi, Isla.
But hi there. You may have answered it. I was wondering, what is the importance to know what's firing at the same time and what's not as a hypnotherapist? Why would I need to know that?
Oh, there's a practical application to this here that you're going to have in a moment. But the other thing is, if you're talking to people who are medical providers, then being able to set things up in terms of how this functions in the brain is going to give you a ton of credibility. I had a surgeon who came in as a client. I asked her, well, you're not a brain surgeon, are you? And she's like, no. I'm like, well, okay. You know, I was kind of giving her like the overview of it, and she was like, this all tracks. It makes total sense. It's a credibility boost. And I also think that, you know, I remember a line from one of the Star Trek movies where Captain Kirk says, you got to know how things work on a starship. And I think that it is helpful for us to have at least a basic understanding of what's happening in the brain when we use these processes. By being able to demystify it a little bit, I think we can speak to our empirical culture. It also kind of helps me as I think about how to craft processes and what's actually going on with my clients. So it's not necessary to remember all this, but if you want it, it's there. And like the research is definitely there. So when people are like, oh, hypnosis, you know, it's hokum or whatever. Well, no, like there's hundreds of articles, there's tons of things that are peer-reviewed, scholarly. Like we've got just great support, which you're going to see as we kind of go forward. So I'm going to grab a little bit more sharing and hit that. All right, so hopefully we get to some things that seem a bit practical to you as we go along. And I think this kind of gets into some of the practicality. And Art, when I'm thinking about people that come into my office that are hypnotizable, there is some correlation between hypnotizability and diagnosis. So the hypnotic induction profile, which is a measure of hypnotizability, scores correlate between high scores on the HIP, an individual with post-traumatic disorders, functional neurological disorders, and anxiety-related disorders. So a functional neurological disorder is someone who has a medical symptom, but there's not a medical cause. For example, I've just completed work with a young man, a 12-year-old, who had psychogenic seizures. If you have epilepsy and you have seizures, then the neurologist can look at an MRI and they can see the seizure in the brain. But what if you run the MRI and there's nothing's wrong with your brain? There's nothing structurally wrong with your brain. Then it's a functional neurological issue, which is an emotionally driven issue. Another name for this is conversion disorder, and the idea is that an emotion is converted into a physical symptom. I don't tend to use that language because people confuse it with conversion therapy, which has to do with like gender identity and stuff, and they are not related at all. But that idea that emotional effects can affect your body, and there's not really a good treatment either medically or with standard psychotherapy for functional neurological issues. But hypnosis works great for it. I did about 3 sessions with this young man, and we've eliminated the symptoms. Like, it's gone as an issue. And I actually do some of the stuff like I was describing with Krista Dora there, where I'm doing some catalepsy and stuff when I'm treating that kind of thing. In the DSM-5, which is the book everything gets diagnosed out of, this is the American Psychiatric Association's diagnosis book. They note that individuals with schizophrenia have low hypnotic capacity, but individuals with dissociative identity disorder, which is the fancy new name for multiple personalities, have the highest hypnotic capacity among all clinical groups. So when we think about correlations between hypnotizability and diagnosis, what this suggests is that hypnotherapy is going to be effective for traumatic disorders, anxiety disorders, including like unipolar depression, functional neurological disorders, dissociative disorders, not effective for disorders correlated with low hypnotizability, such as schizophrenia. And I think that's what you see in clinical practice. And it also suggests, we need more study on this, that the same brain functionality underneath high hypnotizability contributes to the cause of these disorders that are correlated. In other words, hypnosis is operating in the same manner in the brain as these kinds of disorders are created. The same brain functionality is in place. I'm not saying that hypnosis causes these things, but that when you're using hypnosis to treat these issues, we're taking advantage of the same brain functionality that got you in trouble in order to get you out of it. So these are actually chapter titles from the DSM, and that is a lot of the book. Like if you look at all these chapters, every one of these except functional neurological, which fits underneath somatic symptoms, which is body symptoms. These are chapter titles from the DSM. Hypnosis is great for treating all these things. And Art, when someone walks into my office, like I've had people go, well, do you test for hypnotizability? And I'll go, well, no, because like the person's got an anxiety disorder or a trauma disorder or something. So I know they're highly hypnotizable. Like they correlate. Like the disorder itself shows that they're highly hypnotizable. And this is quite a list. And when you can sit down with like medical and mental health professionals and go, okay, there's a neurological basis to hypnosis, and it is good for treating these things because of the way it operates in the brain, now we're cooking with gas. So did that help a little bit? We got a little more.
It's
Yeah.
mind blowing.
Yeah.
I love it.
I'm glad
And there's
it-
one line in that I use a lot is the same part of you that, decided this was, something you wanted to do is now motivating you to be free of this
different
thing,
choice.
making a different choice, because it really is the same part of you, the same suggestible part of you that thought that starting that horrible bad habit was good for you or would be a good idea. We're using the same part of that brain to say, no, it's actually not a good idea.
Right. And the people that come in with these kind of issues, and so if I get someone and they come into my office and they're actually presenting with schizophrenia, like I can treat that under my license, but I don't. Like my process is not real good for it. What I'll do is spend some time with them to refer them to someone that can actually help them. We've got real good medication for that stuff, and it helps tremendously for schizophrenia. But you know how low a percentage that is of mental health diagnoses? Like the vast majority, if you're a mental health counselor, the stuff that was just on that slide, that is what like 99% of people walk through your door for. And we are great at all that. And all of those things indicate high hypnotizability. They correlate together. And my money is on that the same brain functionality is underneath all of them, because that would make sense. But I want to put a little more on our table, if that's okay. Would that press on a little bit?
Heck yeah.
Caroline had it.
Okay, Caroline, go ahead.
Hi, thank you. So I'm not a hypnotist, I'm a psychotherapist, and I'm looking to expand into hypnotherapy as part of my work. And I'm finding, a lot of fascination in what you're saying, and really appreciate how you're presenting the information. I'm curious what you're talking about in the prefrontal cortex and the connection to the limbic system, particularly the ACC. So if you have an anxiety disorder, as an example, and you see somebody who's in our language, psychodynamically neurotic, and they're presenting and it's just firing back and forth, and they're intellectualizing everything, they're firing it back and forth. Is that you're saying they're highly hypnotizable because this is really interacting together in my language? Is that what you're suggesting?
Right. What you're going to have if you were to run a brain scan, what you're very likely to have is that functional connection between the prefrontal and the salience network. The anterior cingulate is the thing that keeps showing up as a brain structure and across different articles, and it's part of the salience network. Just for you hypnotists, like I tend to think of the conscious mind as cognitive processing, as frontal lobe activity, which is decreased during hypnosis, frontal and prefrontal activity. And I tend to think of the unconscious or the subconscious mind as limbic system processing. The limbic system is the part of the brain that is just running stress, anxiety, fight or flight, in charge of your survival and keeping you safe. It's midbrain. If you draw a line between your ears and straight back from your eyes, where it crosses is where this sits. And it runs emotional and body somatic responses. And so I tend to talk a lot about, cognitive and limbic, meaning conscious and subconscious or unconscious. Caroline, I think the information on this is like really solid. And yeah, I mean, for treating those kind of diagnoses, hypnosis is a hand in glove fit. I've got a certification course coming up in January. I'd love to have you in. I mean, it'd be awesome.
I love that. I'm really looking not to do a 7-month or 2-year course, but just getting into
5
something.
weekends, and you get certification, and I do nice clinical training. So I would love to have you along.
Sign me up.
Melanie, I hope that was okay. And anybody else that wants to, like, watermarkcolumbia.com, but Sean will have the stuff up. I want to get more on the table because we got about half an hour here. And so I want to make sure that I can give you as much as I can. Melanie, Caroline, was that helpful?
Yes, thank you.
Thank you. So Lane, this is an article that doesn't talk about hypnosis. I don't think it's anywhere in the article. This is a 2015 article where they're basically reviewing different approaches to psychotherapy. And they pretty much say that, look, whatever you're doing as far as a therapeutic approach, this is what has to happen if you're going to create change. These 3 things are the recipe for change with psychotherapy. And so I think hypnosis is great at these things. The first thing is to reactivate old memories. The second thing is to engage in new emotional experiences that are incorporated into these reactivated memories. It's a process of memory reconsolidation, which, Melanie, I think is what you were talking about earlier. And then you want to reinforce the new experiences. A lot of times therapists are giving people advice on how to do this, or they're telling them to go out and, do these things or these activities or whatever. With hypnosis, what we can do is just visualize it and reinforce it through like hypnotic visualization, which is super fast. So I like to pull this slide up because it also is very solution focused. It's not so important to figure out where the problem came from. It really is all about how the person is reacting moving forward. And I think we spend a lot of time digging back into the past and trying to figure out where things came from and stuff like that. I'm a solution focused guy, which, goes back to my roots with good old Milton Erickson. But I figured that this might be helpful for you to see, because this is the current take on what we're doing within psychotherapy if we're going to do something that functions, whether it's CBT or hypnosis or behavioral approaches or humanistic approaches or whatever you're doing. These are the things that need to be hit, and hypnosis is great at these 3 things. I'm not going to spend a lot of time on these next two slides with state and non-state theories of hypnosis. I mean, basically the idea that hypnosis is just kind of role-playing conscious compliance, and we're doing stuff in hypnosis because it's what people are supposed to do when they're in hypnosis and stuff. Like, just brain studies at this point don't support that. Non-state theories don't make any sense in terms of modern neuroimaging, and so if you want to talk a little more about that, we can, but I want to get to something that's more interesting. And that is that hypnotizability is genetically inheritable. And there's a test on the market for it right now that costs about $20, and it will test hypnotizability. So it has to do with the COMT gene, and maybe there are a couple of other genes that are involved. Corday, this is a very interesting study. Used this test, so it's the Genetech Discover 500 collection kit, which is not designed to test for hypnotizability. It tests a bunch of genetic things, but it does test the profile on the COMT gene that you need to look at. And so this test will test hypnotizability. That COMT profile also, though, correlates with, and this is where Corday went with the study, if someone has, for instance, surgery, and they have this profile, this genetic profile, they're more likely to experience more pain than the average patient, and opioid treatments are less likely to be effective for them. So when I was teaching my psychiatric residents, the physicians they could all be your GP. They're all fully practicing physicians, and they're getting their specializations in psychiatry. And of course, they've all been through the medical rotation where, like, as part of their training, they go through all the specialties. So I was like, let's say that you decided to be a surgeon. And they're like, oh, no, I don't want to be a surgeon. I'm like, yeah, okay, but let's just say for a minute you did. And you did surgery, and you had a patient, and they are exhibiting a lot more pain post-operatively than you thought they should, and you gave them opioids, it didn't work, what would you do? Every doctor in the room raised their hand and went, give them more opioids, which actually makes sense, like up the dosage. But what you see here genetically is that people with this profile of the COMT gene, opioids, they're likely to experience more pain, and opioids are less likely to be effective for them. But you know what? They are highly hypnotizable. So hypnotic pain relief is likely to work really great for them, which is exactly what Corday recommended in this study, that hospitals test genetically patients before surgery to see if opioids are likely to work with them, or if we should just use hypnotic pain relief anyway. Older studies, by the way, show that hypnotic pain relief for just anyone going into surgery, used in addition to traditional anesthetics, lead to better clinical outcomes, shorter hospital stays 89% of the time, also less opioid use. But I'm going to stop here for a moment and let you ask questions, because, like, this is a couple big things. Is it helpful? Art, you're going to have to turn your microphone on.
Yeah. Do you have the documentation for that study that you just mentioned, the last one?
Yeah, it's the Corday study, and it is in the references of the slideshow.
Okay, I'd really like to have all your handouts, really. They're just fabulous.
Sean, I will send you a PDF of the slideshow when we get done, and yeah, I'm happy for it to be distributed.
That's okay. All right.
And if one of you wants to contact me directly, I'm going to have a slide up with my address on it, but it's watermarkcolumbia.com, and I'll be happy to send the things to you, and I'm happy to correspond with you. And especially if you're interested in the class in January, so that'd be great. Callie.
Yeah, hi. Thank you so far. This is so interesting. I recently left, I was 6 years at an outpatient pain management. It was OT, PT, and social work. And now I'm in private practice for hypnotherapy. But it was a challenge. I had been doing hypnosis for 10 years, and people, kind of what Caroline said, the people there had chronic pain and had failed traditional treatments of opiates or surgeries, or they had other injuries or past life traumas that added to their symptoms. But I learned over time how to use hypnosis with them, but it was challenging. Sometimes people that are in a heightened fight or flight have trouble, at least maybe you can speak to this, or somebody I recently had with very kind of obsessive thinking. I feel like they are hypnotizable, but it's hard to get them to either trust or to let go enough to drop into hypnosis. So like in the real world, I feel in research it's one thing, but in the real world, sometimes it's hard to get people that might be highly hypnotizable, but they've had life experiences that have made them either difficult to trust others or guarded or scared. So I've had a lot of learning over the last 6 years, and now I'm kind of getting back to more lay people, not just really traumatized people.
Well, the nice thing about being in private practice and telling people that I do hypnotherapy is that the people that come through my door are self-selecting for hypnotherapy. I don't go out and grab people and drag them in off the street. Now, if you're working in a more general clinic, I can see how you're working with that. I believe in, I mean, one, there's just fundamental rapport skills, which I'm sure as a social worker, you've worked on and honed those. But that initial rapport and connection with someone, and that emotional connection, I think is really critical to honestly any kind of a successful therapeutic process, but especially hypnotherapy. When I'm working with like budding young counselors and supervising them, I'll tell them when you're working with your client, you can feel your connection with your client, like you can physically feel the connection with the client. And if you're ever in a session and you don't feel that connection, you need to stop because they're not on board with you. It's like mirror neuron communication. They're not on board with you. And at that point, the best thing that's going to happen is you'll say things that are really nice and worthwhile and helpful, and they won't do them. The worst thing that will happen is that you say things that are really beneficial and helpful, and they do the opposite. So at the point where rapport is lost, you just have to reestablish that rapport. You can also frame things in terms of guided imagery. I find that that's helpful sometimes. I do believe in being honest with my clients and the people I'm working with. But if I tell you it's hypnosis and you're like, no, and I tell you it's guided imagery, you're like, well, okay. I mean, we can just put it into an imagery process and do something with that. And also, I mean, some people, especially with pain, it's like people get desperate, like I just want some relief. And I'm like, okay, I can help you. And they're like, I don't know about that. And I'm like, why don't you just see? Give me like a minute and let's just see. Honestly, our topic tonight is not pain relief, but if you don't do hypnotic pain relief, you need to be doing it. It's super simple. It is so simple that almost direct suggestion just works great. Very simple visualizations will work for this, and it is so meaningful for people. Also, OCD is an anxiety-related disorder, and it is definitely in the group of things that we treat real successfully. And people that are exhibiting OCD behaviors are probably highly hypnotizable because it's that same coactivation pattern in the brain between the prefrontal and the anterior cingulate that is very likely to be underlying both things. But really, Callie, the thing that you're hitting an important point, like, people don't care what you know till they know that you care, and you've got to have that sense of connection. I'm going to grab just a little bit more to put more things on the table for us, because we're getting kind of down to near the end of the slideshow and more chatting. But thinking specifically about pain relief, in 2019, the Department of Health and Human Services did a big giant best practices report on pain relief. This covers medications, it covers medical devices, and it covers behavioral and psychotherapeutic treatments. And what they found was that over in the behavioral and psychotherapy area, most approaches to psychotherapy can help people cope with the experience of pain better. However, there was a small group of psychophysiological approaches that actually changed the experience of pain. It's us, hypnotherapy, biofeedback, and relaxation training. So everything else that we have in the mental health world, when we're dealing with physical pain, everything else we have is about helping people cope with it better. With hypnotherapy, biofeedback, and relaxation training, you can actually eliminate the experience of pain. It is recommended, hypnotherapy is recommended by the Department of Health and Human Services in this report, not only as standard of care, but as best practice. This is a medical best practice for treating pain, which is huge. And the report, by the way, like if you Google it, you can find this. It's a government document. So like when you look at the link that's in the end of the PowerPoint slide, like you just put in the link and like it'll take you straight to it. And then when you go into it in the table of contents, just click on behavioral and psychological approaches and you'll see it. Art, I saw your hand. I'm going to pull up just the next slide because they kind of go together. And then we're really at the end of the show. But I will pull right over to you. So hypnotic pain relief, I'll explain in a moment when I get the PowerPoint slides off. But also a history of trauma contributes to increasing sensitivity to pain. And remember, people that are more highly hypnotizable are more likely to experience post-traumatic responses that are clinical. Doctors don't tend to talk to each other across disciplines. So if you've got someone trying to treat pain and you've got someone else that's trying to treat like the trauma, you've got a high likelihood of co-prescription of opioids and benzodiazepines, and that is a recipe for opioid dependence. Those are a couple of medications that should not be put together. And it was something I was very happy to like flag my psychiatrist to because, I mean, our specialists need to do a better job of kind of looking at what each other's doing. So I'm going to flash up this screen and I'll leave it up for just a moment and then I'll turn off the screen sharing. But there's my my email address, and then Melanie put watermarkcolumbia.com in the notes. So thank you. Art, you had a question for me. Would you like to go ahead and ask it?
Yes, some of the training that I've had about pain over the last 40 years has said if you have someone coming to you and says, I have pain, then you ought to find out, you know, what rating do they give it on 0 to 10 or 0 to 100 or whatever it is. And then to tell them that we will not remove all of this pain because that is a signal to you that something is not operating correctly. And it would not be appropriate for me to remove all of that signal because it may be something that somebody else, you know, can use as a significant piece of information and know what to do about it. But just, oh, I've got bad headaches. Can you help me get rid of the pain? Yeah, we could, but not a smart thing to do. What if you got brain cancer? You know, I don't want to interfere with your body's ability to tell you that something's not right. So what's your feeling about that?
You definitely have a very legitimate point. I want to give you some different framing on that. Very quickly before I stop the sharing, you just like, you asked me about documentation and like all the references are right here.
Fabulous.
And so like, there's the Health and Human Studies report. So that's available for you. So, okay. I'm going to explain pain relief to you the way I would explain to a client. And I think it'll reframe that a little bit. You've got a legitimate point, but I think there's a different way to handle it.
Good.
So I'll say, all right, here's my amazing magic trick. Notice how my fingers never leave my hands. You're not aware of your shoes until I mention them, and now you feel your shoes. Or if you're barefooted, now you feel your feet. And they're like, wow, I do. And I'm like, yay. Well, what's happening? Well, there's a signal that's going from your foot up to your limbic system. Limbic is stress, anxiety, fight or flight, in charge of your survival and keeping you safe. Constantly monitoring all sensory input for threat or non-threat. Feel your hair if you got it. Feel your clothes, peripheral vision, smells in the room, everything that's going on. Limbic processing is fast and vast. It is at least a third of a second faster than cognition, which is why limbic problems happen before cognition and why cognitive therapy can only try to treat the reaction, like be reactive to limbic problems, because limbic stuff is happening first in time, at least a third of a second, which is enough time to feel, not like a nanosecond, like a physics construct. And limbic processing is vast. It handles tons of information, way more than neocortex processing. So your neocortex, which is the little voice in your head you think of as you, it handles a lot of information really fast, but limbic has got it going on. The nice thing here is that you're not aware of most sensation coming into your body. If you were constantly aware of all of it, it'd drive you crazy. So let's say you get a cut on your hand. The signal goes from your hand up to your limbic. That is a wound to the body. And so the limbic is definitely going to send the signal. It's a nociceptive signal, but send the signal up to the higher cortical structures. Ow, I feel pain. Pain is not the wound to your body. Pain is the registration of the signal in the higher cortical structures. What you see on neuroimaging, and that's, I'm not talking psychologically or metaphorically, that is a medical definition of pain. It is the definition from the International Society for Pain Studies, who are the people that define all this. Anyway, what you see on neuroimaging with these processes, hypnotic processes, is we fuzz up the signal between the limbic and the higher structures. The thalamus is actually the gateway. The signal doesn't get through, and so you don't feel pain. We're not fixing your body. So if you got a bad back and you can't lift certain ways and bend certain things, I can get your back to stop hurting, but you still can't lift certain things or bend certain ways. But here's, I think, the key. If you've got a bad back, we could give you a medication that you totally are not going to feel your back at all. Probably wouldn't be able to walk. And if a bee came along and stung you on the back, yeah, you wouldn't feel that, which is also a problem. But what we're doing with hypnosis is we're kind of fine-tuning that limbic system so that we're saying, hey, that signal that has to do with that herniated disc right there, message received, we don't need it. We can totally let that go. But if a bee comes along and stings you on the back, remember, your limbic's in charge of your survival and keeping you safe. You're going to feel it. When I do hypnotic pain relief for physicians, it's always fun to watch them because, like, I can get your palm to be completely numb and, like, poke you with something or pinch you and you don't feel it, but you can still feel the fingertips. That makes no sense medically because your nerves go, this way downstream toward your fingertips. And so with a nerve block, if your palm is numb, your fingers have to be numb. And so I got a doctor there and I'm like, pinch her on the palm. She's not feeling it. I pinch her on the finger. She's like, ow, how in the world does that work? And I'll explain it. And she'll like, yeah, but how does that work? Like, yeah, because it's a different model, because what we're doing is we're adjusting things. So I think it's okay to get rid of the pain. We're trusting the limbic system to go, you know what? Something is going on here that you need to know about, and I'm going to send that signal through, because that is the part of you that's in charge of your survival and keeping you safe. The other point, too, is that pain is an important diagnostic symptom. I don't like to treat weird, odd, undiagnosed pain. I can get a tumor to stop hurting, but the cancer still kill you. And so, if you've got someone who's coming in, they got weird, odd, undiagnosed pain, they're not ready for my treatment. The doctor needs to take a look at that. Most of the time, though, people that are coming in know exactly what happened. It's arthritis, or it was that real bad traffic accident, or whatever. Or I get these migraines. Like, they know what's going on. But it is kind of the idea of trusting the person's processing, their limbic, their brain processing, to actually take care of them. So that's a little bit of a different spin.
Good, thank you. That's helpful.
Is that helpful? So
Yes.
we've got, I don't know, I think about 7 minutes here or so, or Melanie, it's kind of up to you. I think we're a couple minutes in when we started, but I'm happy for questions, comments, observations. Was this helpful?
Yeah, this is amazing. You gave me some pretty good insight on likely my own personal experience with some massive pain prior to and following a surgery that I wasn't a fan of opioids, and they, told me there was nothing else they could do. So I did end up taking them, and it seemed to make the pain worse. And for the longest time, I was like, hypnosis is woo-woo BS. I have nothing to do with it because I'm a science mind. And then I met her, and, she talked about some of the neurochemistry and, the neurology of it all. And I was like, okay, well, that makes sense. And then she did hypnosis on me on the beach on a bench. And I was like, well, this isn't going to work. Right. And she just said, well, just, you think it might work? And I'm like, maybe. And she said, that's all you need. And that pain, and I tell people, I still know the pain could be there. It's just different. It doesn't feel like pain. It feels like
A signal that says, you know,
Be
you
careful.
probably shouldn't move your broken back like that. Just be careful.
right, but it's not like it was at all. So that's pretty insightful.
There you go.
Yeah.
But the
I'm glad.
whole, you probably have the gene that makes you suggestible, which he does. I'll just guess. And then that means that the opioids won't work so well for you. Like what a brilliant thing that every hospital should have on their protocol.
Exactly
right?
the
Every
recommendation in that
student.
study. So there you go.
Amazing.
Other questions?
How do we help make that test part of the process in general? I mean, as the general public, how can we help make that, to let the medical field know that that's, why is that not being done? Why give somebody opioids if it's going to make them worse? Why not do the test?
If I were, talking to my surgeon, I might just hand him a copy of the Court Aid article.
Sure.
There might not be enough pharma money in it, as the first thing that comes to my mind.
Well,
Okay.
Well,
Sure.
okay. I mean, yeah, I hear you, but I mean,
I love it, but
I've had a lot of medical and mental health professionals as clients and people that I've worked with, and I'm not going to say people are not driven by money, but in general, I feel like, Callie, yeah, post the research. In general, I feel like, I feel like most of these people really want their patients to do better.
I think the
They really
doctors do
want
want it.
their patients to do better.
No, I absolutely believe that.
Also, honestly, not to be cynical, but if the test costs the hospital $20 to run, they're not going to charge you that for it. They'll charge you more,
It'd be
which is
200.
fine, but then you're not taking all the opioids, so that'd be great. But
That'd be
also, they
great.
got to have someone in there trained to do what we do, to
Exactly.
do the
Not a
pain
pain.
relief.
Right. Absolutely. Well, this is one of the, initiatives that we have is to educate
The
the
Hypnosis
Hypnosis
Education
Education Association, to educate the medical field about, just the basics, just the basics. But this is next level.
Well,
And
welcome to the party. Here we go. So there
Yeah.
you go. Yeah, there you go.
Awesome. Thank you so much.
Yeah, I'm thinking press release.
Yeah, for sure.
You and I will get together because we have a series of press releases coming up, and in the new year, in the first quarter especially, and this ought to be one of them. So
Lori, exactly right. Seth Dever does a great job with that. Internationally, there's a guy, a good friend of mine, Giancarlo Russo, who's just absolutely fantastic that does this stuff.
Seth Dever
There are a
and-
number of different people that will do. Oh gosh, I'm trying to think of who else I know that's working in a hospital. I can see her face. I can't think of her name. Anyway, yeah, there are people that are doing this stuff. And I tell you what, that Health and Human Services report is strong. Like, Health and Human Services recommends hypnosis as a best practice
right.
for pain relief.
That's good.
Yeah.
So okay, standard of care, when you think about what does it mean to be standard of care, whether you're a treatment or a medication or a device, you think in terms of statistical terms of reliability and validity. Reliability is how often it works. Nothing's 100%, but it's got to work pretty well for it to be standard of care. And then validity is, does it work the way we think it's working? There's an old fraud where a guy would come into your home with a light meter and start telling you that your windows were drafty because, look, when I put the meter near the window, like the needle just shoots up. Well, it's a light meter, so Mr. Sun is going to make the needle shoot up, but doesn't have anything to do with draft. So the meter works real well, but it's not valid for measuring drafts. It's measuring light. So validity is, does this thing work the way we think it works? Science likes to have a model, and they want to know things work, and they want to have a model of how it works. So that HHS report also talks about a bunch of different approaches to psychotherapy. Some of them are standard of care. Some of them are in the complementary realm. And complementary basically means, and we're looking at the NIH definition, that there's a problem either with reliability or validity or both. In other words, it works pretty well, but maybe not quite well enough to make it standard of care. or it works really well, but we can't figure out how it works because the explanation that goes with it doesn't make any sense. And so, you know, if we've got something where we've got pretty good reliability, but we don't have like good validity, doesn't make sense, complementary. Or if it works some of the time, but not great, but yeah, it does help people and it's got pretty good validity, complementary. The third category the NIH has is alternative, and I'm just going to say it because like this is what your medical provider is going to hear. That is probably fraud. Alternative treatments don't have reliability, they don't have validity. It's possible that there are some folkway things out there that like actually could help people, but honestly, every day people are trying to write PhD dissertations, and like if there's something out there that kind of works, like I promise you there are people that are trying to run it down. And so like an alternative treatment, just in the NIH definition, I mean, it will be called fraud in a peer-reviewed article. It is,
Right.
it just doesn't have reliability or validity. And so complementary treatments are supposed to be used in addition to standard of care. They're complementary, but hypnosis is not complementary. We're sure as hell not alternative. We are standard of care. We have excellent neurological basis for our process. And we don't need to apologize for
Yeah,
it.
this is so helpful. 6 years ago, that paper came out, you said, by the HHS, and or 5 years ago, and I didn't even know that. All those years I was doing it as like an additive to some patients, but I mean, also the system didn't allow me to, because under my occupational therapy license, I had to do A, B, and C. So hypnotherapy was, so I feel like there's systemic issue, or the way things are set up, not maliciously, but it just, there's a lot of barriers. And I guess that's what I was talking about earlier, like people that have been through the system, patients, sometimes they don't trust hypnosis, or even if the rapport is there, there's something else. But, and I just want to mention, I know we're over time, but Sue, I don't know who you are, Sue, but I feel that same way. Like she mentioned like wanting to get really deep in hypnosis to benefit. And sometimes it's hard to get to that, but like I have, and I really benefited from hypnosis in my own life. So wanted to hear your
Tend to
thoughts.
worry about depth, but it's, you know, I'm an Ericksonian guy. Like my Swiss colleagues are like, you have to get down to like these very deep states. And they actually did a neuroimaging thing like last year that like I was super surprised they were able to show a difference between what they called estale state and what they called somnambulism. And like there was actually a difference in these levels. I haven't found depth to be a particularly helpful construct or really meaningful in working with people. But Callie, there's an interesting article about social workers doing pain relief in a hospital setting with hypnotic language, which was basically hypnotic language without an induction, and psychotherapy and mindfulness, which mindfulness, by the way, is the opposite in the brain of hypnosis. Like they are actually inversely related. Like people that score high mindfulness score low hypnosis and vice versa. And totally different things are happening in the brain. Like mindfulness is just straight up like consciousness on steroids. And it doesn't get rid of pain, it just makes it less meaningful or significant, which is kind of helpful. But anyway, they did those three things. It was real interesting. Like the hypnotic language without even induction just reduced need for opioids, got rid of pain. I know I'm over, Melanie, like, thank you.
Hey, there's no over. We can, we can wrap up here
long
by
as you're cool.
7:45, as long as you're cool with questions. I think the conversation and what is being revealed with your answers is incredibly valuable to everybody who's here and everybody who will watch the replay. So if you're cool, we can go for another 10 minutes or so.
I'm happy to take a few more minutes if people
Awesome.
have things they want to ask me. But if people need to bug out because, like, you had plans or something, like, we won't be offended. So, like, I do want to be respectful of everyone's time.
Of course. And Caroline had her hand up.
Yes.
Oh, I forgot I even have my hand up. Oh, let me remember the question. And you were talking about best practices, or somebody had mentioned best practices. You were talking about standard of care. And I was thinking about the licensing boards for psychotherapists and psychologists, and the scope of practice. Like we can't practice in certain areas. So when people come in and they're telling us, I have chronic migraines, 13 days a week, or I have juvenile rheumatoid arthritis, and now I'm a young adult with RA, and we're not able to, because of ethical reasons and legal reasons, we can't go into it. And I think this is such a great adjunct to put into the space, right?
Well, diagnosis is somatic symptom disorder with predominant pain and go treat it.
Right. What I notice when I see these things come up in the two descriptions I just gave, and I could go on and on and on, but I won't.
Right.
The people here, is there's always a high anxiety and a high level of neuroticism that's going in the space with this, and it's often associated with OCD in the space too. It's not uncommon, and they stay in the pain and the anxiety, and it moves. It's not just the pain; it's usually moving around. I think you.
Well, they reinforce each other. In fact, like I've got a presentation coming up for the Counseling Association here in February, where I'm basically asking the question: do we have an ethical responsibility to prevent PTSD? Because my thinking on this is we've got a genetic test that can tell us who is more likely to experience post-traumatic responses that are clinical. Why don't we run that test for people that are looking at going into jobs that have a lot of trauma?
Mhm. That's a great question.
And also we know that, like, not only is it just emotional trauma, we also know there's people are more likely to experience higher levels of physical pain if something happens that's physically painful. So to my mind, like right now, we could screen people like military, firemen, police officers. And, I don't know that we tell someone they can't be employed, but I think we at least let them know, hey, you know what? You might not want a job where like there's a lot of trauma around.
Hmm.
We got a genetic test for it.
It's pretty amazing stuff. I'm so glad I joined. I'm gonna have to leave now, but it was nice to meet you. I'm gonna message you. Nice to meet everyone. Bye, Lori. I love you, Lori.
Caroline, please do email me. I'd love to be in correspondence. I saw Art raise his hand, but Illa has had her hand up for a while, so I want to make sure I get a chance to grab her.
It's Isla, and
Isla, I'm sorry.
That's okay. I've had this name all my life. You're not the first. You were talking how simple pain in hypnotherapy, hypnosis is. I've never heard that. It's very simple, pain relief with hypnotic. I took a certification. It was a one-day thing at the college I went to. Do you have a class or a book on it that I could learn from?
Yeah, like one of the books is let's see, it's the let's see, let me get back to this. The one on the kind of not the far right, which is I wrote an introduction to a book in German. The one that says RBPR, that is a book that is I put that together as a 2-day training for physicians on hypnotic and related pain management. The Different Reality book has a script in it for just a wintertime visualization. And the Emotion and Power Change book has a script in it for, I think it's called Garden Walk in there, but I kind of think of it as the summer process. It doesn't have an induction with it, but it's, basically, if you think visual, auditory, kinesthetic, pain is kinesthetic. And if you can change it to a different modality, visual or auditory, or to a different kinesthesia, then that helps. So the summertime process kind of does that. So like all three of my books have got something on pain relief. And I'm not, it's, bad form to tell you, well, go buy my book, but like, thank you.
No, if you have something,
Yeah.
this is a place to go. I have no problem acquiring or periodicals and
I'm
books.
actually doing a week-long training next October on hypnotic pain relief, but it is in Germany. It'll be in English, and then they're going to be translating it. But they're probably not helpful. But I'm looking forward to it. They were like, can you do 2 days on this? I'm like, yeah. And they're like, great. And then they're like, we scheduled for 4. And I'm like, I'll talk slow.
Okay, that helps. That even is encouraging. Trying to do a pain management seminar that only takes 2 days, and now you do it well with translation. It can take 4 days.
Yeah.
I guess that may be the thinking, but I don't know. Germans, they're interesting. Art, you had your hand up a minute ago.
Yes, 2 things. One is I wanted to know, is the course you're getting ready to offer, is that on Zoom or does it have to be in person?
Oh, it's available on Zoom. I only have 2
On
spots
Zoom?
left in person, and as of today, And so, yeah, you can take it by Zoom from anywhere. I've had people take it from, like, I had a woman take it last January when I taught it, from like Argentina.
Wow.
So yeah, like, if you can get the time to overlap. I had a woman in like West Canada that was getting up at all hours of the morning to take it, and it's, if you'll get out during the time when it's there, I'm happy to have you along.
Great. Okay. The second thing was I found the notes that I got such good help from you last time. It was on Parkinson's disease.
Oh yeah,
And-
yeah, that Israeli study.
Yes,
They were able
uh-huh.
to reduce movements per minute by a factor of 10 with hypnosis, but unfortunately the effect only lasted like I think like a couple of hours.
But I have a client
Yeah.
who says that few hours is worth everything. I mean, it's just fabulous. So thank you very much for that. All these, I guess months, maybe years later, is still working.
I'm so glad. Yeah, like, it means you can record a process for someone and they have to go to a big event like a wedding or something. They could just like listen to it, and they're going to have like, it would reduce. It's been years since I've looked at that study, but it would reduce it by a factor of 10 from like 200 and some movements per minute to like 20.
Like 20.
And in the study, as I recall, what they did was just basically like a guided imagery, like nature visualization.
Yeah, well, it wasn't much to it really, but
It was
it
like
worked.
I think it was an Israeli study. I may be wrong. Lockman or something. I'd have to go find it.
Yeah, that was a good one.
Thank you.
Wow.
So who's jumping into Hollywood
To
and
help-
going to help some people with hypnosis, and then
And
they
make it-
become spokespeople for hypnosis because they've got the reach in the sphere of influence.
He means for the people with Parkinson's. Like,
Yeah.
Happened with crazy things like Scientology. Why not us? So, there you go.
Yeah.
Right on.
Awesome. Wow. I want to thank you. This has been absolute brilliant. Your genius is clearly a blessing to the profession, and we are looking forward to making sure that many more people, many more people, I was saying pin and more at the same time, apparently, because I was pinning you, get this information.
Yeah, this is a really, really, really good one. We, again, after this, like, we got to take off tomorrow, but I want to reach out to you as a follow-up on this about a few different things. So thank you so much
I'd
for
be happy to chat with you.
sharing
Thanks
your
for having me
super
along. I appreciate
powers.
it.
Yeah.
Anyone else, or we're done? Y'all have a great evening, and thank you very much. And I really appreciate it. And Melanie, Sean, thank you for having me.
Thank you for joining us on HEA's Hypno Connect, the podcast by the Hypnosis Education Association, a not-for-profit organization serving the hypnosis community since 1998. Proudly sponsored by Hypno Biz in a Box, the all-in-one platform for building a thriving hypnosis practice without burnout. If you enjoyed today's episode, be sure to follow, leave a review, and share it with a fellow hypnotist. Ready to grow with a supportive educational community? Join the HEA today and help us spread the word about the nature, uses, and benefits of hypnosis. Visit us at hypnosiseducationassociation.com. And if you're looking to get started, streamline, or scale your hypnosis business, head on over to hypnobizinabox.com, where you'll attract steady clients, generate reliable income, and be supported by a community of like-minded hypnosis professionals. Until next time, find a hypno buddy, stay inspired, and stay connected to HEA's Hypno Connect.